Good morning, everyone. Good afternoon for those of you on the East Coast. Good morning to those of you on the West Coast. Thank you all so much for joining us today for this webinar on NTM lung disease. Before we get started and I introduce our wonderful panelists and speakers for today, I wanted to cover a few housekeeping items. At the bottom of your screen, there are multiple application engagement tools that you can use. All of the engagement tools are resizable and movable, so feel free to move them around to get the most out of your desktop space and experience. You can expand your slide area or maximize it to full screen by clicking on the arrows in the top right corner. If you have any questions during the webcast, you can submit those to the Q&A engagement tool. We will do our best to address all questions during the webcast, but please note that the speakers cannot offer medical advice or speak to specific treatment options. The resources referenced in the slides are also listed in the resources segment or the resources list on your screen, and we encourage you to use those links and save them if they're helpful to you. I know that our speakers have found them very useful in their work. For the best viewing experience, we recommend using a wired internet connection and closing any additional browsers or programs that are running in the background, as webinars can be bandwidth intensive, and we want to make sure you have the most smooth viewing experience. And if you are having any trouble seeing the slides or they aren't refreshing for you, F5 will refresh your screen, and that's normally a quick fix to address that issue. An on-demand version of this webinar will be available afterwards and will be shared with you via the email you registered with, and we will also be sharing that with additional folks afterwards, and you're welcome to share with your community as well. And now, I am very pleased to just go over a few other things before we bring in speakers. First, we have a couple of disclosures. This event was sponsored by INSMED and participants were compensated for their time. Second, a brief review of the agenda and what we'll cover today. We will focus and begin with our welcome and introductions and our housekeeping notes, which you are here for right now. We will then move into an overview of NTM lung disease and cover some of the diagnosis and testing, both from the patient and physician perspective. We will then also move into lifestyle changes and management, as well as some great resources that Debbie has helped us to put together. And then finally, we'll move into the Q&A. So please, do share your questions with us throughout as they come up, and we're happy to pose those to the speakers at the end as best we can. And so, without any further ado, I am so pleased to invite you to welcome our two speakers today. Debbie B., who is our patient perspective, a patient with NTM lung disease, who has been just a pleasure and has some great insights to share today about her experience. And of course, Dr. Patrick Flume of the Medical University of South Carolina, who's going to share his expert perspective from the physician and diagnostic experience. And I think they both have really great insights. So thank you all so much for joining us here today. And with that, I will turn it over to Dr. Flume to take us into the next slide.
Well, hello, everybody. First, why are we here? Well, obviously, we all have an interest in mycobacterial infections. Whether it's because we study it, we treat it, we have it, or we know someone who does, we all have an interest in mycobacterial lung disease. We're here to talk about NTM, non-tuberculous mycobacteria. You'll hear it used in a number of terms like NTM lung disease. Sometimes people will call it NTM PD or an NTM pulmonary disease. They're all the same definitions. This is still considered a rare condition. What defines a rare condition is really from a regulatory perspective of where there are fewer than 200,000 cases, but we are finding more and more people affected with NTM every year. Ourselves, we started our clinic a little over a decade ago, and it seems like it just keeps growing and growing. And looking at large data sets and recently published in the literature, we are finding more people identified with NTM lung disease. For example, the number of subjects per 100,000 people has increased from a little under 7 to almost 12 persons per 100,000 over just that short time period. Now, for some, that is because we just have a greater awareness that these are people who had it, and with the evolution of high-resolution CT scanning and greater interest and knowledge of the subject, people are identifying more patients with the diagnosis. But there are also concerns that there might be more people at risk to develop the infection. And so we're still trying to learn more about that. Many lung diseases that we see, many chronic symptoms and chronic lung diseases will present with similar symptoms. So the diagnosis of NTM lung disease isn't as easy as people would like it to be. And for many people, they will go for years before the correct diagnosis might be made. But it's important that you know what lung disease you have, because we do have specific therapies for each of these different types of lung conditions, and we want to make sure that we're treating people in a personalized manner. NTM lung disease can be serious. It can be progressive in some patients, and when it is progressive, it may cause permanent damage to the lungs. And so we would prefer to be able to make a diagnosis as early as possible so we can identify those patients who are more likely to have progressive disease to intervene even earlier. So during the rest of this session, we have a few objectives. I want to talk more about what I mean by an NTM lung disease, how we make the diagnosis, a little bit about treatment options, give you an idea of how the patient should talk to their doctor about NTM lung disease, what kinds of questions they should be asking, how do people learn more about whether they're truly at risk or experiencing any symptoms, and then also where you can go to find additional support. So what is NTM lung disease? Well, at its simplest, this is someone who has a lung infection and is caused by these mycobacteria. These mycobacteria are ubiquitous. I mean, they are everywhere. They're in the water supply. They're in water in general. And so you can see here a couple of images of where that might be. And so we are all being exposed to these mycobacteria. So these mycobacteria are in our normal environment. There is no escape from them, and we are going to be exposed. But in many people, they are exposed to NTM, but it doesn't do anything. They come in contact with it, but their normal host defenses are able to fend it off, and the mycobacteria are not able to establish residence in the lung and cause infection. And so having a good nutritional status and good health is important to try and prevent infection. Now, Mycobacteria is actually a pretty large family. In Mycobacteria, tuberculosis is the one people probably have the most knowledge of. So we're talking about all the others besides tuberculosis. So there's a lot of cousins in this family. There are nearly 200 species that have been identified. There are some that we find commonly, and you can see them listed here. Abscessus, avium complex, so M-avium complex, we more affectionately call it MAC, Kanzaceae, Malmoense, and Xenope. There are some which are relatively uncommon. We can find them on occasion, but we don't really find them frequently. And not all of them are pathogenic, that we find them in cultures, but we don't believe them to be actually causing infection or even there in the creating problems. And so when we talk, these are most common. MAC, as I said, is probably the most common, accounting for more than 80% of the cases that we see in the clinic. So who gets it? If we're all being exposed to it, why do some people get it and others do not? Well, they have conditions which render them more vulnerable to infection. So obviously people who have underlying lung disease, it kind of makes sense that these opportunistic organisms could get into the airway and find a way to be successful and multiply. And so people who have COPD or chronic obstructive lung disease, patients who have bronchiectasis, this includes cystic fibrosis patients, or those that have bronchiectasis due to other reasons, and even some people that have asthma. People who are immunocompromised, their immune system is not totally up to snuff, renders them more vulnerable. But then there are people that we don't quite know why they're more vulnerable, that we find these people that have infection and and we don't find an immune deficiency or some other medical reason to account for it. It's why we typically see it more commonly in women, and we see it more commonly in people as they get older. From an epidemiologic standpoint, we look to where these bugs are, and are there areas that are at greater risk, and typically that's where there's a lot more water. So it's much more common in those people who live near coastal regions. What are the signs and symptoms of NTM lung disease? Well, it's a little bit tricky because it's a lung infection, and so obviously there can be respiratory symptoms, and these are typically cough, sometimes productive of sputum, not always. The sputum might be ranging from clear to white to actually looking much more infected, so greenish, yellowish, darkish, and some people might even cough up a bit of blood. But then there are other symptoms which are clearly constitutional. They're systemic symptoms. It's kind of like having the flu all the time. And so people may complain of low-grade fevers, having night sweats, kind of sweats that they sort of soak the sheets kind of sweating. They may lose their appetite and experience weight loss, malaise, or fatigue. And so fatigue is a very common symptom. And so these are very non-specific symptoms, both on the respiratory and these systemic symptoms, and could mimic other conditions, which is oftentimes why these diagnoses are often delayed. But now I'm speaking to you from the perspective of a clinician seeing these patients, and now might be a good time to hear from Debbie, who has been through this.
Well, hi, welcome, and thank you for having me. I am grateful that there are symposiums such as this one, because when I was going through this, and it has been a long journey, there was very little information. So for years and years, probably 15 years before my diagnosis, I felt I had a chronic cough. Anytime I'd get sick, it would last for a very long time. And I went from one doctor to another who didn't really understand. At some point, they told me I had borderline asthma. Then the next time, no, it wasn't asthma, but they didn't really know. But I was experiencing things like fevers, chills, hot flashes, mainly the cough, though. And before I had the symptoms, I was very active. I enjoyed skiing, golf, and hiking. And I was always up for anything that was fun to do. But eventually my symptoms got the best of me, and I was reluctant to be around people, especially when I coughed, because I got these serious looks like, stay away from me. You're going to give me something. That sounds very bad. So anyway, at some point, the turning point for me was at a family dinner. And when I arrived, I felt hot, cold, tired, exhausted, and I had to go to bed. And turned out I couldn't be with my family for the dinner. I was very disappointed, and it was obvious to me that something was wrong, because normally if I don't put it into my schedule, I say to myself, I can't be feeling this way because I have no time. But actually, I found out later on it was important to make the time. So that was the beginning of my journey, and I'll come back and talk more about it in the next few minutes.
Thank you, Debbie. So how do we make the diagnosis of NTM lung disease? Well, obviously, first we have to have a suspicion that that might be a culprit. So this is typically going to be done in persons who have the signs and symptoms that are suggestive of NTM lung disease. The ATS, the American Thoracic Society, and the Infectious Diseases Society of America came together to come up with guidelines on the diagnosis and treatment of NTM lung disease. And to make the diagnosis, they established there need to be 3 general criteria. One is that you have the clinical symptoms or signs that are suggestive of the infection. The second is that you have to have radiographic images that are consistent with NTM lung disease. And then obviously you have to have a bug. You have to have microbiologic confirmation. So I've already discussed with you the signs and symptoms that are typical of NTM lung disease. And so when we get to the radiographic features, there are a number of findings. They're not diagnostic of NTM lung disease, but they are compatible with it. And so what we find is our radiologists will more frequently interpret a film and say, this looks like MAC. And to which, of course, it might very well look like MAC, but that doesn't make it MAC lung infection. And so there are a number of people who will be referred to our clinic solely based upon the findings of an X-ray. They got an X-ray done for another reason, and they found something which led to this referral, but they don't have symptoms. So in general, you have to have those symptoms. When we look at these features on the CT scan, and I hope for those of you who have NTM lung disease or family members with this, that your clinicians do in fact share the images with you so you can understand what it is that we're looking at. First one are pulmonary nodules. And what you can see here on this image, the person is on their back, so imagine their feet are coming out at the screen. So to our left is their right, and to our right is their left. And what you can see here is on an X-ray like this, the air is black, and so the lungs should be, for the most part, blackish. There should be some structure and blood vessels, but when you start to see little white densities, that becomes more than what you would expect to see for normal lung tissue. That becomes something abnormal. And so what you can see here on the left side of the image, this person's right lung, you can see these little whitish dots. Those are nodules. And so that can be one feature of NTM lung disease. But as I said, it could be due to other causes as well. Some people will have what we call bronchiectasis. And for those who haven't heard that term, bronchi means airway and ectasis means wide. So as the airways come from down your trachea, branching to both lungs, and then branching out to the periphery of the lung, those airways should be tapering, becoming more narrow, just like the branches of a tree. And so when we look at those airways, we're looking at them to see, are they the right size, or are they larger than they should be? And so what you can see here on this central image is on our right, their left lung. You can see that sort of almost like a tube-like structure. That's an airway extending out to the edge of the chest lung, the chest wall, where you see more dense tissues in the lung itself. So we look at these airways, and if they're dilated, that's bronchiectasis, which renders a person vulnerable to developing an NTM infection. And then there can be other features which are suggesting more destruction happening in the lung, where these are cavities, and these should be obviously apparent to you. That suggests that there has been progression to where lung tissue is actually being destroyed, in part from the infection and in part from the inflammatory response to that infection. So when we look at the images, we look for those features, and we look for changes over time. And then you also have to have the microbiologic confirmation. We need to grow the bug. I don't ever feel comfortable looking at images and saying, well, that looks like MAC, so I'm going to treat you for MAC. Because these mycobacteria, if we do need to use antibiotics, they're treated differently. So you really want to be certain that that's what you're dealing with, and that you're not dealing with perhaps another infection. There are other bacteria that can be involved and give you features like that. So if possible, sputum cultures. So in people who are coughing and producing sputum, that's the place to start. Get that to the lab. If a person can't quite bring it up, we can induce sputum. That's a little tougher to do with the pandemic, but using nebulized saline to try and induce a cough, to try and get some sample there. If a person is not able to provide it in the clinic, we will oftentimes send them home with cups because they may be more productive first thing in the morning or late in the evening. And they always worry about how quickly they have to get that sample into the laboratory. The fresher the better, but we also know that these bugs are not that fastidious. They can hang in there for a while. So I have our folks, if they get a good sample in the evening, don't rush down to bring it to the lab. Just put it in the fridge and then bring it in the morning, and it'll be fine. We have these mailed in to us, so we know these bugs can survive for quite some time. There are some people who are unable to cough up sputum, or we can't quite get the diagnosis, in which bronchoscopy, where we actually put a scope down into that area of the lung and wash in some saline to get a sample, is of necessity. And so we get the confirmation, the laboratory can identify the bug. But a key caveat to making the diagnosis in these folks is that they meet the 3 criteria. They have signs and symptoms, they have x-ray features, they have a bug, but do they have any other reason that they might have those symptoms? And so we want to exclude those other potential diagnoses, because that's what we should treat first. Because if I treat their reflux, if I treat their other bacterial infection and all their symptoms are resolved, then maybe we don't have to get too excited about the mycobacteria at the front end. And so we want to make sure that we've taken care of all the other stuff first. So when we are evaluating someone who has NTM lung disease, we're trying to understand the diagnoses that put them at risk. What's their underlying lung condition? Make sure that that is being treated appropriately. Look for other features that complicate their disease. Might be part of the reasons they got it. I mentioned esophageal reflux. It's actually the aspiration that gets the bug into the airways, but that reflux might be allowing them to get acid into their airways or cause problems with their swallowing. Smoking is definitely not good for anybody, but it's especially not good for people that have NTM lung infection. And so we will really counsel people about the use of tobacco. And then we also want to make sure we're addressing other medications because they might interact with NTM treatment in the variety of therapies that we would offer them. So we want to make sure we have a careful history of what they're taking. Some of the messages that I try to convey to people at the very beginning is, number one, this is a chronic condition. It's not going to go away in a short term, so we're going to spend a lot of time together over the next years even. There are a lot of treatment options available for NTM lung disease. I mentioned why it's appropriate for early diagnosis and appropriate diagnosis. There are published guidelines which were recently updated to give information to doctors about where we are in terms of understanding best practices. And so when I evaluate people and I'm trying to decide if I need to treat the mycobacteria, what I'm getting at here is whether we need to use antibiotics. I want to know why we're treating it, because when I initiate the treatment, that's what I want to assess. If I'm treating you because your cough is bad, then I want to assess if the cough is improving. If fatigue was the issue, have we had improvement with that? Because we're going to need to know exactly what it is that we're hoping to improve. And then there are times in which we don't feel compelled to recommend antibiotic therapy at the time. But what I always tell people is just because that's our current recommendation, we reserve the right to change our mind. Because what we may be looking for is additional evidence that suggests that these mycobacteria are the culprit. If there was a test that I could do that would tell me that you're the patient who's going to have a progressive disease, well, then that's the test I'd want to do. So monitoring is very important. So there's never a time that I would see someone and say, yes, you have mycobacteria. It's not ever going to be a problem. You don't need to come see me again. Like I say, this is about having a relationship. Again, I mentioned that early diagnosis is important, and that's because in some people, this infection can be rather progressive. And I've shown you again these examples of the damage that can happen in the lung. That damage can be permanent and can be very problematic. There is no test I can do to know if you are the person who is going to develop that kind of progressive disease. So when we follow people, we're looking for any evidence of any change in their symptoms that suggests that there's something that's getting worse. There will be a time to repeat the image to see if there's anything on there that suggests that something is advancing, because if it is, that would become an indication to recommend therapy. So the way that we monitor this is looking for those signs of progression. We also will repeat the cultures in part because we want to make sure that we have absolute confidence that this bug is in fact there and persisting, perhaps in bigger quantities. And if we do decide to treat, we're looking at that as assessing the response to treatment. So for example, if I advise you to go on to airway clearance therapies, perhaps with inhaled hypertonic saline, or we're treating reflux and or working on aspiration, we want to find out, well, what's that done for your symptoms? What has that done for your cough? And in fact, what has it done to the change in sputum cultures? And so we will be looking for those signs of progression. And I don't know that we have figured out exactly when is the opportune time to get a chest CT, but probably within that 3 to 6 month range period is what is most commonly done. So now I'll hand it back off to Debbie so she can describe what her journey has been like.
Thank you. So when I mentioned that family dinner a few minutes ago, I realized that I really needed to mitigate my health more because everything I had done up to that point really didn't do anything for me. So I made an appointment with my internal medicine doctor who diagnosed me with pneumonia. And I was surprised because by the time I got that appointment, which was only a few days after that family dinner, I was feeling so much better on my own. So he diagnosed me with pneumonia, but on the x-ray showed that there could be something more going on. He wasn't quite sure what. I think he had lung cancer in the back of his mind, but he didn't share that with me. The next doctor did. So then that next doctor was a local pulmonologist who ordered a CAT scan and put me on a 10-day course of antibiotics. And at that point, he had said to me, "I'll bet my career that this is not lung cancer." And I'm thinking, wow, I'm glad that the internal medicine doctor didn't share that with me. That would have been panic for sure. So anyway, then he ordered a bronchoscopy, and he sent the bronchoscopy out to a sophisticated lab that really was able to pinpoint what I had. And it turned out that it was NTM lung disease. And when I got that diagnosis, and that was 20 years ago, believe it or not, I said, NT what? What is this? I never heard of it. And anytime I'd ask any questions to most of the doctors that I had seen, they'd have no idea. So I really had to find somebody that was a specialist. I figured I've got one life to live, and I really need to make the most of the opportunities out there. And they were slim at that time. Thank goodness in this day and age, there are so many more doctors that know and so much more information that's there. But I wound up going to a specialty center, and those doctors were treating lots and lots of patients. So I kind of had a sense of calm that maybe I'm able to control this thing and it's not going to get me, I'm going to get it. So my initial reaction of shock turned out to be, was calmed by learning and getting all this information. And if there's anything I can stress more than anything, it's number one, pay attention to your symptoms, and number two, act on it and learn as much as you can, and know that some of the things that Dr. Flume mentioned are out there, such as the bronchoscopy, if it's needed, or getting a sputum sample by bringing it up on your own, and also the CAT scan. Those are the two major ways of diagnosing, along with monitoring symptoms and pulmonary lung function testing, which really helped diagnose me. So I do want to say that this is an experience that I've had that has had its challenges. It's been a roller coaster ride. I've been on many antibiotics, including orals, inhaled, and intravenous. And after many years of being on and off antibiotics, they finally found and I have not been on an antibiotic. Not to say that I might not need it in the future, and that's the reason for being monitored. But I do something called airway clearance, which has been very helpful in managing my disease. And so here I am 20 years after the diagnosis. I've learned so much from so many people, and I do want to say that if you get this thing, especially if you get it early, if you diagnose it early, you have a great chance to lead a very active and productive and happy life like I do. Dr. Flume?
Thank you. So we've talked about some of the other management issues, and as I had said at the beginning, treat the underlying causes. So if we understand why one's vulnerable, we can treat those underlying conditions to some extent, treat those other exacerbating features. Airway clearance therapies, Debbie has mentioned that she does airway clearance therapies, and there's a number of modalities that we use. There are none that are clearly better than any other, but that doesn't mean that one might not be better for an individual. And clearly the one that a person will do will be the better one. And so it's one of our goals in treatment is to find what would be the therapy that works the best. Oftentimes using inhaled hypertonic saline to try and enhance clearance of those secretions. If we do feel the need to treat the infection, obviously that comes with antibiotics. And the general regimen with antibiotic therapy in NTM lung disease is multiple medications, generally for a long period of time. And the treatment it will vary for the individual. And so there are guidelines that are published to give recommendations to clinicians, but again, they have to be tailored to the individual. There are also going to be a number of lifestyle modifications. Some recommendations that come out have reasonable evidence to support them. Some are still hypotheses that could be tested. People ask a lot of questions. I always tend to focus mainly on let's get the nutrition as good as it can be. The lifestyle modifications that are an absolute change. Obviously, we talked about tobacco. I try to get people to reduce their caffeine intake because that can exacerbate reflux. People will often ask about do they need to make changes in where they live. If they're in an endemic environment where there's lots of water, they have a pool, a hot tub, other things that might potentially put them at risk. I showed you a shower head at the beginning of all this. People have asked if they should stop taking showers. Again, we got to find what's reasonable for people to try and figure out how to reduce their risk and their complications. And again, we do have treatment guidelines that should be useful to the clinicians. And the goals of therapy, if we are treating the infection, I always tell people if we start antibiotics, my first goal is just to make sure that you can do fine with these. And keep in mind that people take these medicines and do just great. They don't have any issues at all. But nonetheless, we try to create expectations. Every drug comes with its own baggage, whether it's an over-the-counter medicine or a prescription medicine. There is the potential for some kind of side effect. So we're using combinations of medications, so they may not be so easy for some people. But that's where I focus on it because I want them, before we worry about whether it's working, is to make sure it's a regimen they can stick with. Then we can start focusing on the outcomes. Is it having the effect that we intended? Meaning, is it relieving the symptoms that led to treatment? And then is it having a microbiologic effect? And that's where we monitor cultures. In our program, we are trying to get cultures on a monthly basis until we have found them eradicate the infection, or if they are coughing and having sputum production, that they stop having those symptoms. Then it's hard to get that culture. Those are the goals of therapy, and the guidelines outline the duration of therapy depending upon the infection. So I'm going to hand it back to Debbie and let her share her experience after she was diagnosed.
Yes, so it was a shock at first. I think I had mentioned that before. And as I said, once I got on the therapy, I felt like I was more in control. And I felt confident that I was going to be okay in the long run. At the beginning, it's very difficult because you don't know too much and you don't have any history with your health to really see how you're doing. But over time with NTM, you start to see a pattern in your own body. And based on some of the things that Dr. Flume had mentioned, with the right treatment, you start to feel better. And you do realize that you could have exacerbations over time, and that could happen even though therapy is working, and that could happen for many reasons. But my mindset says when that happens and I know I'm not feeling well, I know I will get better because I've seen it in the past. And that has really helped me through quite a bit. In terms of lifestyle changes, at the time I was diagnosed, my husband was soon to be retired, and we were going to go somewhere for the cold weather months to get out of the Northeast. And our plan was to go to Florida, but my NTM specialist said that that was a very humid climate and that it might not be best for my condition. So we wound up changing course and coming to California instead, to the California desert, where the climate was much more dry. And I physically felt a whole lot better doing that than being in the Northeast, where it was humid most of the time. So again, my lifestyle changes. I've enjoyed traveling, but I only travel to places that will be beneficial to my health. So I don't go to Florida anymore, and I don't go to Hawaii, and that's okay. I mean, I can see them on a, on a slideshow or whatever, and I've done that, been there, done that, and look for new things to do. So I still hike. I enjoy that, but I don't do well going uphill. My lungs don't withstand that very well. I get breathless. So I've done some modifications with that, and I hike on flat surfaces, and that makes me very happy because I can still do it and I can go a long distance. I also enjoy less strenuous activities. I play golf. I like to read. I like to work on the computer. And as I say, I've been doing so much better once I figured out what works for me and what doesn't. So one of the things I really needed to do was to find other people with the same condition. Now, 20 years ago, that was very difficult. But I would talk this up to everybody I knew. I mean, they must have been thinking, oh, my God, Debbie's coming. I think I better get out of here because I'll listen to NTM, something I never heard of. But actually, many people were very helpful. And I wound up finding other people that had the same lung disease and in different degrees. And I started the first support group in New York in 2003. And since then, I've also started one in Connecticut and started one in the Palm Springs area of California. And I have met the most wonderful people, made some great friends, people who were caring and intelligent, and were also on top of their game, so to speak. And that was turning lemons into lemonade for sure. So I'm very comfortable with this now. And I just want you to know out there that it's not something that you really need to be fearful of. Great outcomes can come with it with the right medical treatment. Dr. Flume?
I think what we wanted to do is go to the support and talk about resources and let you comment on how you have found these helpful.
Yes, so there is a national organization called NTM Information and Research, and they've been existing since about 2003. They have a great deal of links to information on NTM, treatments and diagnosis and so forth. More recent one about NTM, it's a very excellent website, and it talks about people and their one thing that they're very good about is people's stories and how you can relate, which has helped me a great deal. And the CDC has information, the American Lung Association, and there's also the NTM Lung Disease 2020. There's a group, actually it was a consortium of 4 groups that have come up with treatment guidelines. They started back, they had the first publication probably around 2010, and it was recently upgraded. That's very, very technical information. So if you're into trying to learn about the technical end, the exact medications for the exact diseases, that's a very good outline. it's also a good one to share with your physician who might want to be more educated. And then there are also some online resources on Facebook. So there's so much out there for people who are very interested in learning about it. And I suggest that you have to be your own advocate, get as much information as you can so you can help yourself with your treatment options and guide yourself along.
Thank you so much to both of you. I think that was a wonderful way to wrap up. And, you know, certainly I think being your own advocate is something that I think all of us in the global genes world hear a lot, and I think is a very important piece. And so, Debbie, I'd love to really, you know, kind of pose that first question to you and really ask, what does it mean to you to be your own advocate, and how have you really tried to learn how to be your own advocate in better ways within what we, I think, all know is a little bit of a complex medical system here?
Yes, that's a really good question. And for me, at the beginning, it was difficult because how do you be your own advocate and find the information? So at the beginning, I went online, and of course, you have to be careful with the resources that you find. But I started out with my own doctor, the internal medicine doctor, who referred me to the pulmonary doctor, who ultimately referred me to the specialists. And once I got to the specialists, they knew other people that had the disease. And so I know there are HIPAA laws that don't allow the doctors to give out information, but I did give them permission to give out my information. And so people were contacting me about NTM, and that specialty center kind of realized that I was hungry for information, and that I started the first support group in New York. And after I did that, they wrote me up in their newsletter. And after that story in the newsletter, I must have gotten about 200 responses, which really got me going in terms of finding people. It's very, very helpful to have family support, by the way, but it's especially helpful to have the support and to have the resource of other people that have this disease, because you learn so much from others. Even the doctors say that they learn a great deal from the patient. They're more clinically oriented, and as far as lifestyle, that's what they learn from us. So the support groups have just been such an invaluable resource to me, as well as other people.
Great. Thank you so much. And so, you know, thinking about that as well, I think one of the things that both of you highlighted in talking through this was really, how can you be best prepared when you're working with your doctor, and how can you also find a physician or a doctor or specialist who's going to really be a good fit for you? And so, Dr. Flume, I might kind of direct that to you first, give Debbie a moment off the stardom, and Debbie, if you want to chime in after, certainly welcome that as well.
So there are a growing number of NTM treatment centers. For example, we started our program a little over a decade ago, and are here to provide a resource for the docs and the patients in the state of South Carolina and beyond. And so there weren't a lot of these centers for a long time. So you become dependent upon your physician to send you to the right person. And you want to make sure that you establish a good relationship with a physician, so because things will change over time, and trying to understand when is it an issue, when is it not an issue. Not all cough is going to be an aggravation or exacerbation of NTM. I think that the greatest thing I try to tell people is, you know, it can be overwhelming at the beginning when you go in and you say, I have this cough, and then there becomes a series of tests, and then somebody comes in and starts using terms like NTM and bronchiectasis and trying to put it all together. And Debbie has given you some resources on the internet. I'm always afraid of the internet because people start reading about things that they don't have or we're not going to do, and they are getting way out in front. And so we acknowledge that it's going to take a little bit of time, which is usually why we don't come into a clinic and walk out with a treatment with antibiotic therapy. We want to get to know the person and what's going on. Ask questions, write questions down. You'll leave and have forgotten what you wanted to ask. And I also would encourage having a partner to make sure that, you thought you heard something. Did I hear that correctly? Everyone is now on electronic medical records, which does allow patients to communicate with their healthcare teams to try to understand or communicate how they're doing, or to ask a question to make sure they understood it correctly. Debbie?
Yes, so I'd like to add, how do you find the right doctor? And that's really important. So some of these websites that appeared on the screen have listings of physicians that treat NTM. Most of those lists were recommended by patients who were satisfied with their treatment. And you get to know after a while if your doctor is on the right track, because you learn from the resources, you learn from the other patients what they've been through, and so it's probably a good place to start. And we realize some of them are not near where you live, but you have to realize that NTM is not a situation like a normal medical condition where you call your internal medicine doctor and you say, I need an appointment for tomorrow. It doesn't work that way. Usually it takes a few months and you set up an appointment with an NTM specialist. So if you're not that close, it's probably not a big deal, because in the interim, you can speak to them on the patient portal, and you can speak to your internal medicine doctor, who's hopefully coordinating all of this with your specialist. But it is important to find the right doctor. And if you find that you're not getting the correct testing, or that your doctor is kind of taking a wait-and-see attitude and you're not feeling well, it's time to look for another one. And that's a very important thing to remember. Don't think that once you found your doctor, that has to be your doctor for the rest of your life. It certainly helps to find that right away, but if you don't, keep looking, because there are people out there that know more than other people.
Thanks so much, Debbie. And Dr. Flume, I think those were both great answers. And I know one thing that I think has come up around reaching physicians and figuring out when you need to see them as well is really that in 2020, that's changed a little bit. And there's certainly some limitations in terms of access, but also I think, some patients may be feeling nervous about any additional medical treatment that might require them to go in. And so I know that we have telehealth options. There's certainly other pieces. Is there any advice that you would give to patients looking to maybe follow up after all this great information and try and talk to their physician, but still feeling a little wary about all of the pieces moving around the pandemic right now?
So
well, I would say, I'm sorry, I didn't know who the... No, well, go ahead, Dr. Flume. You're in the middle, and I'll chime in after.
Okay.
Sorry.
So the first part of this is, how do we provide high quality care, and what are best practices? And so our approach when we are treating someone is to see them very frequently, to see them monthly, and to get cultures until we really feel like we're on a cruise control and we can stretch that leash out a little bit longer. Or if we're in a monitoring phase, that might be every 3 months that we're seeing them. And so with the pandemic, that made a lot of things more difficult, but I'm gonna try to find a silver lining on all this. Because where we have arrived now is really what is a hybrid clinic. So as an example, this morning I had a very busy clinic. We had, 22 patients that we saw in the clinic this morning, and half of them were here in person and half were on virtual visits. And so what we've tried to do is to try and figure out well, when are the times that we just need to be in a conversation with somebody? That's all we're really going to do is share information. You're going to answer questions for me, tell me what's going on, what's working, what's not working. But then when are the activities needed when you got to have someone come close? And so whether that's getting cultures or a CT scan or physical examination to try to understand what that is. And we think we're getting closer to that. But what we've realized is, independent of the pandemic, we have people that travel great distances to come see us. And so it's an enormous inconvenience for people, an enormous burden to have to come here, and especially if what we're coming to do is have a conversation that we could do successfully using telemedicine. So we know that when this pandemic is over, we are going to be in a hybrid model from the rest of time, because we even if a person lives close, it usually means a half a day off from work or something to just come in for a quick appointment. And so we're trying to make better use of our resources and our time to try and deliver care effectively, because we feel that we still need those frequent touches to make sure that we're still in contact and communicating with people. If people disappear for 6 months and things happened, that may have a big impact in terms of what's going on with their care. So you want to make sure that if you are going in for in-person visits, that the hospital or the clinic have gone out of their way to make it a safe environment for you, so that you aren't at risk to acquire infection at the clinic. But I don't think people should be afraid of going to see their physician or to take advantage of what telemedicine has to offer.
Thanks so much, Dr. Flume. Debbie, would you like to add anything there?
Sure. I think it is very important to feel like you have access to your physician. And there are some wonderful physicians out there. Dr. Flume is certainly one of those. And it's very helpful when you do find one that's not only knowledgeable, but is sensitive to how you're feeling at a specific time. Telemedicine is a fantastic option. We were hoping to see that earlier on, and it's unfortunate that it took a pandemic of COVID to make that happen. But I've had a few of those visits. It's very, very helpful. And for people who are not computer literate or don't feel comfortable, there's always a phone call. But I think doctors are putting aside time for us now. And before you sit down, if you can prioritize your questions, I know they're busy, but now with telemedicine visits, they're allocating it, probably most of them are allocating a half hour. That's been my experience. Prioritize your questions just in case you can't get to all of them. But you're going to find that people are very interested in the doctors and the other medical professionals that you're using for NTM and other conditions, actually, that we'll give you the time. And I think this world of medicine is opening up now.
Great. That's wonderful. And so I'm going to ask each of you a little bit of separate last questions. But so Dr. Flume, I know one thing that you spoke to a lot was really on two fronts, both the importance of customizing or really taking an individual approach with each of the patients in terms of therapies and mitigation. And I think you also, wove in there a lot of conversations around the importance of adherence and really finding an approach that's going to be something that the patient can adhere to. But could you maybe speak a little bit to the importance of adherence and really finding that balance with patients as well?
So taking medicines is hard. And so when we are treating patients that have a chronic condition, and when we're talking about medicines, so pills, we're talking about aerosol therapies, we're talking about airway clearance therapies, these things take time. It's a chronic condition. So a chronic condition requires chronic therapy. And so what we try to aim for is a routine. How do we help people get into that routine? because that's where we're going to have the most effective approach to this. So airway clearance therapies need to be done every day. How do we get people to engage in that and appreciate that it's making a difference? If we're using antibiotics, we don't want to select out resistant strains of bacteria. And so the best way to avoid doing that is to make sure we're taking the antibiotics as prescribed. If we undertake them, if we take less than we need, that gives these bugs a chance to develop these resistance. The treatment guidelines generally recommend 12 months of therapy after we've achieved culture conversion. And so in general, that doesn't mean 12 months of therapy. It means 12 months plus however much it took to get to that point. And that's to try to reduce the risk of relapse. And so even if we're a few months into it and the cultures have turned negative, that's why we continue the therapy. It's important. And then once we finish the course of therapy, keep in mind that the condition that made one vulnerable to that didn't go away. And that's why continuing things like airway clearance and so forth is so terribly important. What I ask people to tell me is what they are able to do, what they're not able to do, what's working, what's not working. Because if they don't tell me, then I can't help them. So if I believe that they're doing something and they're not getting better, then the tendency is to want to add to that. And so really we want to try to develop success early on with a regimen that works for them.
Thank you so much. I think that was a wonderful answer. And I think it's always important to be honest when working with a medical professional in any setting. And Debbie, I will turn the last question to you before we say our final remarks for the day and just ask, I know that this was a long journey for you, but you've also, I think had some time to reflect on that as well and, have built this wonderful support network around you. And so I'm curious if there's one piece of advice that you might give to someone who is maybe on this path to diagnosis or has symptoms and looking to explore that. And maybe share something that inspires you about the NTM community that, I think you have been such a wonderful part of.
Well, as I said before, it can be very overwhelming when you're first diagnosed with something you know nothing about and you feel that many people out there know nothing too. But one thing is to be persistent, don't give up, look for the best resources you can find, physicians and clinicians and respiratory therapists, and look for support and just keep up with everything. Be compliant. I know Dr. Flume mentioned something about airway clearance and taking meds, but I took my meds when I should have. I did have side effects at some point and many points, and I was able to try to figure out how to overcome those side effects. If you work hard enough on it, you can. Now, I've been doing airway clearance for many years. I do it 30 minutes a day, once a day. Some people need to do it twice a day. And I found that in the morning is my time to do it. And I put that time aside. And what I do is I either work on my computer at that time or read a book. And it's kind of my own special time to relax and not feel that it's a chore. So, I mean, you have to kind of try to find out what works for you. This is a very individualized case by case disease, and it's not one size fits all. And once you can figure out how it works for you and you make the best of it, it could be very, I don't want to use the word perfect, that may not be the right word, but putting some fun activities with it just helps you get through it and makes you realize it's not so bad after all. So what inspires me? Oh, gosh, there's so much. I mean, the physicians I've met, the support group people. It's so wonderful to talk to people and to talk in between meetings about questions that people might have. And we have a very free-flowing conversation, and we're very open, but we invite people to attend support groups. And if they're not comfortable speaking, that's fine too. I mean, whatever works. And if you want to sit there and not say anything and just listen and learn, it's very helpful, and there are different levels of what people get out of it. So although, as I say, it's frightening, in the long run, it can be very rewarding too. So don't give up and keep on trekking, so to speak.
Great. Well, thank you both so much for all of those wonderful insights. And both of you have inspired me today. Really just thank you so much, Debbie, for sharing your perspective and your story. Thank you, Dr. Flume, for sharing all of those insights, and also, I think, a really patient-centric approach to patient care. And with that, I will also thank our audience all for being here today. Again, our disclosures, which we had at the front just to close, and a thank you to our sponsor, INSMED, and thank you to all of you for joining us. If you have any questions, reach out to us after the event. Otherwise, have a great rest of your day all, and you will get a recording afterwards. Thank you to both of our speakers again, and we'll see you shortly.
Thank you.